Good evening. I'm Rob Saldine. I teach in the Political Science Department here at the University of Montana, and I direct the project on American democracy and citizenship. This conference was organized by Dane Scott, Dan Smith, Tom Roberts, and myself, and it's sponsored by the Marine and Mike Mansfield Center, the Project on American Democracy and Citizenship, the Mansfield Ethics and Public Affairs Program, and the President's Excellence Fund. On behalf of these sponsors and my co-organizers, I'd like to welcome you to the 2013 Mansfield Conference entitled The Future of Healthcare in America, Balancing Individual Rights with Social Responsibility. So at the heart of this conference is an examination of the ever-present tension in American political life between the individual and the community. This is a tension we see, I think, in numerous policy areas, but nowhere more so than in healthcare. And while the Affordable Care Act, also known as Obamacare, became law 3 years ago and is a landmark in American health policy, it only underscored this inherent tension. So this conference was organized to examine this fundamental tension between individual rights and community responsibilities as it plays out in healthcare. This is not going to be a conference, I think, where everyone will be in agreement. And in fact, I think we can anticipate some lively back and forth. We've assembled here some of the leading national thinkers on this issue, and they'll be complemented by prominent experts from here in Montana. Most of the sessions we put together are designed to offer contrasting and diverse viewpoints in which one of our featured speakers will present a talk that will then be followed by a couple of respondents and then a moderated discussion. Now, later tonight, here shortly, you'll be hearing from Jack Mudd, but I'd also like to say a quick word about our other featured guests who will take the stage over the next 2 days. Tomorrow morning at 10 o'clock, Jim Marone of Brown University will provide some historical context for our current situation by examining the political battles over health care that set the stage for the Affordable Care Act. Then at 1 o'clock, Ovik Roy, who's a columnist for National Review and was Mitt Romney's healthcare advisor, will present a conservative plan for achieving universal coverage. At 3 o'clock tomorrow afternoon, Wake Forest Law Professor Mark Hall will address the Affordable Care Act's communitarian values, and in particular, whether and to what extent younger Americans should be subsidizing older Americans. Tomorrow's programming concludes with an evening session in the UC Theater, the only session of the conference that won't be here in this room. Tomorrow evening in the UC Theater. That's at 7:30, and that'll bring Jim Marone back to the stage, along with Megan McArdle, a special correspondent for Newsweek and the Daily Beast, and a former senior editor at The Atlantic. They will both directly address the conference's central theme, this tension between individualism and communitarianism in healthcare. And then they'll be joined by Ovik Roy and Mark as the two respondents. The third and final day of the conference will kick off with Megan discussing obesity and arguing that from her perspective, it's an overblown issue, one that tells us much more about the obsessions of the upper middle class than it does about the future of healthcare costs. The conference is going to then conclude Thursday afternoon with 2 roundtable sessions. And I'd like to introduce my co-organizer now, Tom Roberts, who will briefly preview these sessions and make a few additional introductory remarks. Tom has practiced internal medicine here in Montana for 32 years. He's the president of the Western Montana Clinic. He's also a board member of the Missoula Public Health Department, the executive committee of the Montana Medical Association, and the Montana Health Co-op, and he played just an absolutely essential role in putting this conference together. Tom.
I just just want to say it's been great fun to be part of this whole organizational structure. I'm really not that interested in academics. I really care about what's going on with healthcare, and it's just been great to appreciate what we're going to be listening to over the next couple of days. It's very, very clear to me, and it's become clear as I've thought about this and worked on this over the last few months, that our values, who we are as a culture, really determines what our health is. And it actually determines what our health care is. We don't have any better example of that than what we're going to see on Thursday here when we start talking about Medicaid expansion in our state. It's a very, very hot topic. We've got some great speakers. As Rob pointed out, they'll be on both sides of the aisle in terms of this. But I encourage you, as you attend these talks and listen to these discussions, to just think about how our culture, what kind of culture do we live in, what kind of choices do we make for ourselves as individuals, and what kind of choices do we make socially, for our health and for our health care. And that's being played out very dramatically in our legislature right now. So it's been really cool to be part of this and to help bring some of those ideas and some of that process to Missoula. And on Thursday, we're going to really hear it. We've got great speakers lined up to look at it, especially Mike Dennison, who is covering over in Helena, really involved with the legislature. Mike Foster, who's a lobbyist, represents the Catholic hospitals here in the state, is going to have some good insights. We've got Carl Graham, who represents the Montana Policy Institute, wrote an editorial and is a speaker from a whole different perspective than I have about what individual rights are and why we shouldn't expand Medicaid. And then Richard Opper, who is head of our biggest governmental agency here in Montana, the Department of Public Health and Human Services. A great guy and a really good perspective. So that'll be cool. And then we'll be wrapping it up with a discussion about the future of healthcare in Montana. A lot of our great speakers, including Jack, are going to hang around and be part of that. We've got Jeff Fee from the Providence Hospital. And also Monica Lindeen, who really plays a national role in determining how healthcare is going to roll out. We're going to see dramatic changes in healthcare and insurance over the next year, and I've been very fortunate to be part of it. You're all going to be part of it too. I mean, it's changing, and it's going to be dramatic. Before I get off of here, I just want to acknowledge when I first came to the discussion about what we were going to do here, across the table was my old friend Pat Robbins. And Pat has been a real stalwart for the medical community here in Montana for many, many, many years. A really good guy. And he and his wife Kitty have just been great for us. And Pat passed away on Friday. Very, very quick death. It was just great to work with him in his career. And he was helpful in getting us to too. So those are my remarks. Somebody else to talk here?
Well, good evening to all of you. My name is Dan Smith, and I'm serving as interim director of the Marine and Mike Mansfield Center. And on behalf of the center and all of our colleagues here in the Project for American Democracy and Citizenship, the President's Office at the University of Montana, and also the Mansfield Ethics and Public Affairs Program, Dane Scott, who has really been the heart and soul of this conference, along with Rob and Tom Roberts. I would like to also mention that this conference is sponsored as well by St. Patrick Hospital, and Jeff Fee will be speaking on Thursday, as Dr. Roberts mentioned. It's my pleasure now to welcome to the podium Professor Paul Gordon-Loren, who who just moments ago received the Distinguished Mansfield Fellow Award and serving as the first director of the Mansfield Center. And Paul, we welcome you to the podium and thank you for participating.
Thank you. If I were to take you to the U.S. Senate in the Capitol in Washington, D.C., we would all walk down a series of ornate hallways until we reached room S207. This room has a special name. It's called the Mansfield Room. And once inside, we would see a very, very large portrait of Mike Mansfield. It is not a portrait of a commanding, victorious general on a horse. It's not a portrait of a politician exercising extraordinary power. It's a portrait of Mike Mansfield looking exactly like he looked. That is, he is standing, he has his arms sort of crossed, and he has his pipe in his hand. And he looks thoughtful. He looks like he wants to listen to you. And he looks like he wants to help you solve whatever difficulty you might be having. The reason why his colleagues decided to honor him in this way with this special portrait, and indeed in an institution known for its hypersensitive egos, a whole room named the Mansfield Room. He wanted to honor this man, and I might add a former student at the University of Montana and a former professor of history at the University of Montana, not because of his party, not because of the extraordinary power that he wielded, not because of his many legislative achievements. They wanted to honor him pure and simple for his integrity and the quality of his character. For years, they had watched him speak out on behalf of the principles of democracy, rule of law, speak out against war, speak out against bigotry, speak out in favor of human rights, and speak out in favor of helping those who were unable to help themselves. This was the man. This is why his colleagues referred to him, and I quote them, as the conscience of the Senate. One of his colleagues, upon retirement, said the following: honor, decency, fairness, tolerance. These have been the hallmarks, and those qualities, much more than our words of praise to him, will remain his most eloquent tributes forever. It is exactly this legacy that we at the University of Montana wanted to honor 30 years ago when we created the Maureen and Mike Mansfield Center. The initial focus was on ethics and public affairs, both at home and abroad. It is exactly this first objective, and this is the reason why the first conference, the Mansfield Conference, focused on ethics and public affairs. When all is said and done, ethics involves one thing. It involves the relationship between our behavior and the well-being of other people. And our behavior might be what we do, but it also is what we choose not to do, including turning the other way when there's a need, including being silent when there's abuse. And this applies not only in terms of how you and I live our daily normal lives, but it also applies when we interact with others that we live with in larger society. None of us are islands unto ourselves. We live with others. And in this capacity of living with others, we possess two things. We possess rights, individual rights, and we possess responsibilities. Responsibilities not just to our self-centered selves, but responsibilities to others with whom we live in society. Normally, course of our daily life, we might not think too much about these issues of rights and responsibilities, but there are two exceptions. One, when we think that our own rights are somehow been violated, we will become very exercised. And secondly, when large questions of public policy are raised, we're forced to confront this relationship between rights on the one hand and responsibilities on the other. Such is the case of public policy today as we deal with the future of healthcare in America. Now, healthcare as an issue of human rights fundamentally began to enter the public discourse in the middle of the 19th century with the emergence of the Industrial Revolution. People are worried at that time about health. But it received even greater attention after the three catastrophes of the Great Depression, the Second World War, and the Holocaust. And immediately after that, in 1946, the international community gave its strong support to the Constitution of the World Health Organization. And in 1946, all of the members of WHO, and all of the members who signed this Constitution, including the United States of America, affirmed the following, and I quote, "The enjoyment of the highest attainment standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition." End of quote. Now, this principle was reaffirmed a short time thereafter by the Universal Declaration of Human Rights, which also speaks clearly about the right to health. But that leaves us with the question. You put this in the Constitution of the World Health Organization. We can say this is one of the fundamental principles of the Universal Declaration of Human Rights. This is the statement, this is the vision. The question is, how do you bring it to reality? How do you take this vision, how do you take this dream and make it real? The world has struggled with exactly this question. That is, should healthcare systems be based upon rights guarantees, as is very commonly done in most industrialized democracies in the world, or should it be based on a market-dominated financial system that treats healthcare primarily as a commodity, as in the United States? Today, our nation is struggling with exactly this kind of question about rights and responsibilities. The way to deal with this issue is not to hide from it. It's not to address it with quick phrases and political slogans, but to address it head on, exactly as Mike Mansfield would have done. That's the purpose of this conference. That is, to talk about the practical and the moral challenges of healthcare reform in the United States. To do this, I cannot imagine anyone more qualified to address this issue than our speaker this evening. Indeed, it is my honor and pleasure not only to introduce an expert on this subject, but a very close personal friend. Jack, welcome back to Missoula. With reference to his education, Jack earned a bachelor's and a master's degree in philosophy from the Catholic University of America. He received his JD degree from the University of Montana Law School. He received his LLM and JSD degrees from Columbia University Law School, and relatively recently, Gonzaga University awarded him an LLD degree on the basis of his work in healthcare leadership. With reference to the question of law, he was engaged in private practice for a number of years, often focusing on his role as a mediator and an arbitrator. And the reason why that's important is that you try to seek practical and just solutions to very specific kind of problems. He served with distinction as a professor and as the dean of the law school at the University of Montana, and in this capacity worked not only to revise and completely revamp the law school curriculum, placing particular focus on practical dimensions, but it was also in this capacity that he was extraordinarily helpful to me as I had the privilege of directing the Mansfield Center. Following this, he served as the Senior Vice President of Providence Services. He then served for 10 years as the trustee, 5 years as the chair of the board of Ascension Health, based in St. Louis, the largest non-for-profit health system in the entire United States. Today, he serves as the Senior Vice President for Mission Leadership of Providence Health and Services. This not-for-profit system was originally started in 1856 by the Sisters of Providence. I might add the same order of nuns that created St. Patrick's Hospital in Missoula, Montana. Now, in order to appreciate our speaker tonight, you have to understand the magnitude and the scope of this system. It entails 32 hospitals. It entails over 300 physician clinics and many services of extended care, hospice, home care, housing, and education. This system has over 64,000 employees. Over 2,000 of those are physicians. It provides millions of dollars in charity, health care, and community services each and every year. Jack Mudd's responsibility in this system is to see that the historic mission and the ethical values of Providence are reflected in the system's decisions and in its practices. When I had the privilege of serving as director of the Mansfield Center, I relied heavily upon the advice and the wisdom of Jack Mudd. And in this regard, I was always struck by two particular features of his counsel to me. One were just remarkable insights about the practical dimension of how life was lived and how institutions worked and how the political realm operated. And secondly, a powerful and a profound sense of ethical values and the importance of keeping the moral compass true. For all of these reasons, I can think of no one better to address the subject of the practical and the moral challenges of healthcare reform in America than Jack Mudd. So please join me in welcoming him back to the University of Montana as our keynote speaker tonight.
Well, thank you very much, Paul, for the kind words, and it's good to be back in Missoula. It's great to be at the University of Montana. And it's great to see so many people interested in the future of healthcare. I'm going to be speaking this evening about something that touches all of us, as has already been mentioned. Like education, healthcare is universal. One way or the other, we end up having some kind of healthcare, some kind of health need. It may be early in our lives, it may be late in our lives. But we all have it touch us in some way. As Paul mentioned, I have the great good fortune to work in a healthcare system, Providence Health and Services. Now, I'm going to say some things this evening that people in this room are not going to agree with. At least some of you, I presume, are not going to agree with some of the things that I say. And I suspect that some of my colleagues may not be agreeing with some of the things that I may say. But I'm going to do the best I can to call it the way I see it. And so right at the outset, I'm going to say that I am speaking for myself and not for the institution that I have the privilege to serve within. Healthcare is the largest single chunk of our economy. It takes up currently about 18% of our gross domestic product. 1 in 8 people who are employed work in healthcare. It, as I said, touches all of us. And this evening we're going to be exploring some questions around healthcare, some of which may be familiar, some of which may not be so familiar. But my hope is in framing some of these issues around the tensions in healthcare, that the experts that you're going to have the privilege of hearing over the next couple of days will be able to answer some of these questions. But they are not questions that are answered from a technical standpoint. There are facts that are critical. But what is most important for an educated citizenry, like all of us are supposed to be, is to understand what the facts are, and then to do the best we can to frame the issues, as Paul so eloquently stated, Mike Mansfield was able to do. Because these are not easy questions. And in the next few minutes, I don't pretend to have answers. But if we can be a little clearer about some of the tensions that Paul mentioned between our personal rights and our collective responsibilities in society, then maybe all of us can make a little bit of progress toward finding answers that will work in this state and in our country. This conversation is very timely. As Paul mentioned, you can hear it in the legislature, you can hear it in the halls of Congress, you can hear it in any healthcare organization today. We have been, and we'll talk about this more, for some years headed toward a cliff. Not a fiscal cliff, but a health care cliff. And the new Affordable Care Act may help us buy some time, but it's not going to fix the fundamental problems that we're going to be talking about in this conference. It is a step. What it has done for sure in the healthcare world is to sharpen some of the issues. It has given us a platform to debate, as our legislature is now doing. How should we handle our health? The tensions are fundamental. They are tensions between what I do with my health, and then when that health goes south, what is the responsibility of the community to help me with my care? It's a tension between free market economics, which is the hallmark of our country, and collective responsibility and oversight for something that touches everyone. It is the tension between individual practitioners of healthcare and large organizations, whether they're governments or large systems like ours. How do we navigate that? My hope is to frame some of those questions, and to do so in a way that perhaps will be provocative, I hope will be provocative, so that over the next couple of days, and perhaps in questions here, we can have a conversation. Let's start with the fundamental questions. Who should be responsible for health? Pretty simple question. Who should be responsible for health? Well, we start off by saying, well, of course I should be. And then we get to the next question. Who should be responsible for helping restore health? I can't do that for myself. I need people like Dr. Roberts to help me. I need people like the hospitals in this community to help me. And what we know is that if my health gets really bad, I individually may not have the resources to pay Dr. Roberts or other physicians or nurses or highly trained technicians or the hospitals to take care of restoring my health. So now whose responsibility is it? Let's just hold those two questions. Our starting point for healthcare in this country, I think, is we have terrific healthcare professionals. Every day, I go to work with people, physicians, nurses, technicians, administrators, who are superbly trained. I think you can make a strong case that in this country, we have some of the best clinicians, best trained clinicians in the world. And so we start with that. We are very fortunate to have the quality of healthcare professionals that we have in our country. We give these very fine healthcare professionals confusing policy decisions. We have a fragmented approach to how we should take care of health and help restore health. For example, if I'm in the U.S. military, I have free health care provided by military hospitals and military physicians, all paid for by my country. Now, we don't like socialized medicine politically in this country. That's a nasty word, but there's no greater socialized system in our country than the U.S. military. And if you look another step beyond the military, the Veterans Administration is also a government-funded, mostly government-run health system to take care of our veterans. So that's one approach for one group of people, a very important group of people in our society. In the mid-60s, we decided that our senior citizens ought to have some health insurance. So we developed a health payment system called Medicare, which, unlike the military, does not provide doctors or hospitals, but pays doctors and hospitals for the care they provide. Today, there are just short of 50 million people on Medicare. That is a health payment system. We also decided at that time that if individuals were too poor to afford their care themselves and did not have employment to help pay for the care, that we would help those individuals. So we developed another health payment system for a category of people that were did not have the resources to pay for themselves. We call that generally Medicaid, or Medi-Cal in California. A second payment system, payment for services rendered by physicians, hospitals, and other healthcare providers. For the rest of the people, the thought was you would get healthcare coverage, insurance coverage through your employer, a system that was started primarily during a time when wages were controlled because of the war, and unions needed something to get, or employers needed something, and unions encouraged employers to provide health care. Historically, that's what happened in our country. That's why we ended up with employer-based health care, unlike the rest of the wealthy countries of the world. And today, about 56 million people get their coverage from their employer. But something else has happened in the intervening time since World War II. And that is, more and more people are self-employed, more and more people are unemployed, and we have what we often call the working poor. They are employed, but they are employed without the benefit of health care. Today, there are approximately 50 million people in that category. If the Affordable Care Act works as intended, about 32 million of those will be entitled to some kind of coverage. And increasingly, there is a large underinsured group of people. Even if you have health care coverage through your employer, it is increasingly difficult to pay the co-insurance, to pay the deductibles, to pay the maximum limits, beyond the maximum limits. And it is estimated, and I'll be giving a lot of numbers here, they're all subject, I think, to some real scrutiny, but as best can be determined, there are at least 100 million people who are underinsured. In other words, if they have some kind of catastrophic illness, their insurance would not cover it. talk later about the Time magazine article that appeared not too long ago. Those of you who read it will hear some stories about people who were underinsured. So this is the fragmented system that we have. There isn't a coherent policy to it, other than we have decided that we will do things differently for different categories of people. Our system is primarily a payment for sickness. Sometimes we call it fee for service. So if I go to the hospital, if I've got insurance, the hospital will, my insurance will pay a fee to the hospital for my care, fee to my physician and other clinicians for my care. It is really not a payment for health. It is a payment because they gave me help for my sickness. So we have a payment for sickness program in this country when we do have some kind of coverage. Now there are some exceptions to that. There are groups, Kaiser would be one of them, that basically is an insurance company that has its own hospitals and physicians. By and large, most of us are in, one way or the other, this payment for sickness program. Some results of this, and we'll talk about this as we go through. First of all, there is a limited access from our citizens. We have 50 million people who are uninsured. We have another group of people who are underinsured. We have the highest cost. We spend more money on care for sickness in this country than any other wealthy country. And, as we'll talk later, we have a poorer health status than most of those countries. Now, again, that's going to be controversial, and some people are going to say, well, but wait, what about this? But folks who have studied this, independent people who have studied it, it's quite clear we spend more money, and it's quite clear from a variety of sources, whether you look at mortality statistics or whatever, that we do not enjoy the same level of health. That's not necessarily because of our health system. Socioeconomic issues play a big role in that. But overall, this is the big picture of what we have developed in our country. I want to look at three questions tonight, three areas that will perhaps help focus the conversations over the next couple of days. First of all, the quality of care that we have in this country. And again, I start with the premise that we have some of the best healthcare professionals in the world. The criticisms that I'm going to share here are some of the facts and statistics on the way we organize our care is not about our healthcare professionals. Second, the efficiency of the care. What it costs us to deliver this care for sickness in our country. And third, the area of personal responsibility that Paul teed up so well, the personal responsibility for our care. So let's look at the issue of quality. And again, I'm not talking about the quality of my physician or my hospital or my nurse. That's a subject for another conversation. I'm talking about the quality overall of what we have in this country. Because we have a payment for sickness approach to payment, a couple of things happen. When I am paid as a physician for taking care of somebody when they are sick, not to keep them well, you can talk to the clinicians here, with perhaps some exceptions. What I hear from the clinicians that I work with is the frustration of having some of their patients not following their medications, not monitoring their glucose for diabetes, not taking care of themselves, maybe because there's nobody there to help them. They may need somebody to follow up, and physicians will say, I can't do that. I'm not set up to do it. And oh, by the way, nobody pays for that, generally. Nobody pays for that. But if that diabetic patient who's not monitoring their glucose properly, either because they can't or they won't or they don't have the resources or somebody to help them do it, if that patient crashes and burns, then we'll send them to the hospital, and then the price may be thousands and thousands or tens of thousands of dollars. They may stay for a couple of weeks, get stabilized, and then go back out and the cycle repeats again. That's one of the consequences. If you look at what happens with chronic disease, and again, the clinicians here can talk about individual stories, that's what we have, because we have a payment for sickness. So we wait for somebody to get sick, sometimes very sick, and then we say we will pay our providers for the service. That's the policy that we have adopted in this country, intentionally or not. So the result of that is usually delayed care. Instead of getting somebody in early, often they come in late. And if they do not have insurance at all, they come in very late. It's estimated, a recent Harvard study estimated that approximately 45,000 to 50,000 people in our country die each year because they do not have health insurance. And you may know stories, I know stories of people who delayed taking care of a cancer, delayed getting the x-ray that they needed to have, or the mammogram they needed to have, or the colonoscopy that they needed to have, and by the time the cancer was found, it was too late. I would expect almost everybody in this room has had that kind of experience. Just to put that into context, assuming these researchers are correct, 45,000 to 50,000 people die each year because they do not have health insurance in the wealthiest of nations. That's 10 times the number of people who were killed in Iraq, our soldiers. And that's every year. So, we have delayed care. Overall, not the quality of the clinicians taking care of these people, but overall, the quality of health care in our society is poorer, and, oh, by the way, the cost is much greater. So, just as an example, looking at one area, chronic illness, where a lot of these things happen, 75% of our healthcare spending relates to chronic illness. 7 out of 10 Americans die from chronic illness, and caring for patients with chronic illness in the last 2 years of their lives accounts for 32% of all Medicare spending. This is a big deal. It's a big deal in terms of quality, and it's a big deal in terms of cost. But there are some different approaches out there. There are signs of hope, and this is one of the things there are some changes. For example, there's a program that's called All-Inclusive Care for Elders, or PACE program. We don't have one, I don't think, in Montana. We operate 2, one in Oregon and one in Seattle. In this program, where you provide all-inclusive care, in other words, these are frail elder folks who are among the most needy medically. We are able to keep them in their homes. We provide the nurse to make sure that they are taking their medications. We provide the social worker to make sure that somebody is there to help them when they need help. We provide the occupational therapists and so forth. It's an all-inclusive program. And oh, by the way, when you provide that, hospitalizations go down 40%. The readmission rate for folks in the PACE program, the average readmission rate for a Medicare patient, 30-day readmission rate after they have been discharged from the hospital and have to come back, the average readmission rate is somewhere around 20%. The average readmission rate for the patients in our program is 7%. There are nearly 50,000 people on Medicare. There are presently less than 100,000 people in PACE programs. Something to think about. But it's a program for care, not just a program for sickness. And it does make a difference. There's a very interesting experiment that I encourage you to watch carefully. Don't know if it's going to work. But in Oregon, Governor Kitzhaber, who's a physician, he was in office some years ago, was out of office for a while when he was term limited, came back in, and he's made healthcare his #1 goal. And so in Oregon, what he is doing is they're looking at their Medicaid population, the folks on their Medicaid program, and Governor Kitzhaber has said to the providers in the state of Oregon, I want you to take groups of these Medicaid patients and provide all-inclusive care for them. And to oversimplify this, he said, here is your check. Providence has 30,000 of these folks because we are the largest provider in Oregon. Here is your check. You will take care of these 30,000 people. Keep the quality up. Keep the patient satisfaction up. And oh, by the way, if you don't do that, you can't cover any of our other state employees. They're out of your system. So he created a carrot and a stick, and he said, good luck. Here's the money you have to work with. We don't know if that's going to work. But it's probably the right thing to do, at least to try it. Because now our system is responsible for 30,000, to keep 30,000 people healthy, not just to fix them when they come into our ERs. We'll see what that experiment may produce. So the quality challenge is, how do we shift incentives from payment for sickness to payment for health? How do we do that? The social policy questions that I hope you're able to talk about in the next couple of days. Who's responsible for changing these incentives? Is it the consumers? Is it us? Is it the providers, our clinicians? Are they responsible for changing that? Is it the insurers or the payers? Is it the government? Who should change the incentive? Is it all of the above? That's worth a very important conversation. As long as we are paying for sickness, we will get the same result. Let's look at efficiency and cost. If we look at spending compared with other wealthy nations, our spending it's about twice the average in terms of what we spend. As I say, our GDP as a percentage is about 18%. The average is closer to 7 to 8% GDP spent in other countries. Norway in this particular year, this was the data from 2008, which is the second most recent year. That data shows that we spend 50% more than the next highest nation on our citizens. If we look at spending compared with wage growth, thank you. Wage growth of American workers, wage growth of American workers had between 1999 and 2012, wage growth was about 47%. The CPI was about 38% growth over that period of time. Healthcare costs, overall, the overall insurance premiums went up 172%, and the contribution that workers are now paying for those who do have insurance has gone up to 180%. So what some folks have said is that in our country, we don't have a debt crisis. We have a healthcare spending crisis. And we'll see some other numbers that at least make that to be a decent position to argue. For efficiency, what value are we getting? Now, I don't know how you judge the value, but a variety of organizations have looked at overall health status of folks in our country and compared it with other places. This is going to be very controversial. But here is one that came out from the Institute of Medicine, which is as serious a research group as you'll find. And the title of the report released in January was this: U.S. Health in International Perspective. Subtitle, very simple: Shorter Lives, Poorer Health. Now, they don't blame that all on our healthcare providing system. There are a lot of other factors. But overall, we're spending twice as much money as the average, and we have poorer outcomes overall with health. The market is supposed to be efficient and effective. The market has not been efficient and effective in our country on health. This is another one by the Commonwealth Fund. Red is bad, green is good. The United States and Canada have a lot of bad. The UK actually has a lot of good in terms of this particular group. Let's look at another measure of efficiency. Spending and waste. Now, as soon as I say waste, somebody will say, oh, by the way, what is waste? Well, again, the Institute of Medicine, very serious group of people, looked at our 2009 spending in healthcare, which was 2.5 trillion. It's now about 2.7 trillion. That's with a T. And this is what they came up with. They said that each year, we waste 30%. Now, I don't know if they're right, but these are pretty smart research. Let's assume they're wrong by 100%, and we only waste 15%. When I first heard a number like this, when I entered the healthcare world about 12 years ago, it was a serious healthcare economist, and he said at the time that healthcare wastes, he said 33%. And over the last dozen years, as I've talked with people that I consider to be very smart people, whether it's clinicians on the ground or people who study these things, I have never heard anybody say that we waste any less than 20%. Now, what do these folks say we waste it on? Well, they said that we provide $110 billion a year in unnecessary services. Unnecessary services are defined as those that do not add value to the patient. Tests that are unnecessary or duplicated, for example. We'll go into that later. I'll stop there. $190 billion in what they determine to be excess administrative costs. Now, some people would say, I'm an administrator and I'm in excess administrative costs. And that may very well be true. After you finish this conversation, you say, yeah, there's one where we can lose some money. But $190 billion on excess costs. We'll talk a little bit later. We have 1,300 approximately insurance companies. If there's any provider in this room, just say, how much money do you spend on trying to identify how to fill out insurance forms for your patients? The American Hospital Association has been trying for over a decade to get the insurance companies just to use a common form. How hard can that be? Has it happened? No, it hasn't happened. So somebody, and I know I'm talking with particularly physicians in small groups or sole practitioners, the amount of money that they have to spend just to help their patients fill out their insurance and then go through all the red tape is part of it. There's another piece in here too that the Affordable Care Act at least tried to get at, and that is some insurance companies, not all, but some insurance companies spend way too much money on profits in terms of investor, and we have a lot of investor-owned insurance companies, and they have to pay their investors a profit, advertising, administrative costs, and so on. So the Affordable Care Act said that you've got to spend a certain amount of money on care. They regulate it to try to at least bring it into line. We have an insurance company as part of our system, which is a big help in today's world. And our people are very upset if they even approach 10% administrative costs. And the Affordable Care Act wanted to get it into the 15 to 20%. $130 billion in inefficiently delivered services. Any of you who have worked in the healthcare system or have been a patient in the healthcare system, just ask yourself if there hadn't been a more efficient way of doing things. Some groups are terrific about it, and folks are getting better. It's not the clinicians, it's the systems that the clinicians use. Excess prices, we'll talk a little bit about where some of that might be. There's a lot of fraud. Anytime you have a lot of money, you're going to find a lot of fraud. and missed prevention opportunities. I don't know whether this is right, but if it's even close to right, imagine, we were arguing in the Affordable Care Act about $500 billion as a big deal over 10 years. This is $765 billion every year. There's something to be done here. Here are a few causes. One is just incentive for volume over value. What we know for sure, and this has been demonstrated in a variety of ways, that if you bought a big piece of equipment and you are providing services with that piece of equipment, you got to pay for it. And if you have multiple pieces of equipment in the same community, oh, by the way, the use of those pieces of equipment goes up. Not necessarily the quality of the care, but the use of the equipment goes up. Now, is that because these people are fraudulent? No, I don't think so. It's because of human nature. And if I own the testing equipment and there's some question about whether I should do the test or not do the test, I'm likely going to do the test. The government's made rules about physician self-referrals because of that. We just don't, but nevertheless, our incentives are still for volume over value. We pay for volume. Lack of coordination. Something that struck me very odd when I first came into the healthcare world was that for years, 20, 30, 40 years, I don't know, we've been able to scan a jar of peanut butter in a convenience store. You know, we still don't have common information systems in healthcare where that can be done. You've got your system, I've got my system, somebody else has got their system. It's a fragmented patchwork. You would think that somehow we would come together, but the market encourages segregation. It does not encourage, in this case, integration. So we've got fragmented information systems. We've talked about the payers. And we've got a fragmented cottage industry historically. That's changing rapidly, but historically we had cottage industry providers. This hospital over there, that hospital over there, this group of providers here, the sole practitioner there, and somehow it was, in the old days, it probably worked pretty well, but in today's world, with the kind of sophistication we have, it works increasingly poorly. Legal processes. I have to say something about this, although it's likely that these are not big deals in terms of the overall spending, but we still have rules that prevent folks from collaborating in communities. You can't have a conversation around services, joint services in a community between hospitals without running into violation of antitrust rules. Now, is that smart? I'm not sure. Interestingly, as a history in Montana, there were two hospitals in Great Falls, two competing hospitals in Great Falls for almost a century. They decided in the 90s to come together. Before they came together, they were the two highest priced hospitals in the state. You would think that they would be lower prices because they were supposed to be competing against each other. They were the two highest priced hospitals in the state. You working with a special piece of legislation that basically overrode the antitrust requirements. The legislature allowed those two hospitals to merge. Today they're called benefice. And in the first years, I don't know what it is today, but in the first years, they went from the highest to the lowest of hospitals of comparable size. But you can't do that with antitrust. We don't know how to deal with medical errors. People make mistakes. We have a system that was designed for a different purpose in a different time. Now I'm going to offend both my plaintiff's lawyer friends and my defense lawyer friends. How smart is it when you've got a very complicated medical case, if you look at it from an overall standpoint, and you need to get somebody compensation, how smart is it to turn it over to a lay jury? I always thought, and we've got an expert on doing that here in this community, in the audience tonight, and he may have some specific thoughts about it, but when you're turning something over to a jury, and you've got one expert here who said this met the standard of care, and this is a great expert from this medical school, and you get another expert from another place who says, no, that didn't meet the standard of care, they can't agree, so you ask somebody who works in the gas station. So we do. Now the Europeans look at that and they say, how foolish is that with those Americans? And I love the jury system. It works very, very well for many things. But you have to say, how smart is that long term? So we don't know exactly how to do harm. There are some experiments in the Affordable Care Act that may help. And then there are financial rewards. The present system, with $2.5 trillion, 2.7 this year, you can imagine that some people are making a fair amount of money. And I don't mean to point to just one, but here's a statistic that caught my eye. The lower red bar here is what the average Fortune 500 firms made during the period of time from 1995 to 1999, in 2009. The upper bar is what pharmaceutical manufacturers made. There are real incentives to keep things the way they are. Many of you, I'm sure, saw this article. There are some things in it that are not accurate. The writer did a fine job of describing a real situation. And overall, it's a very good article, and I commend it to you. There are two things that, at least that I know, that are not accurate. One is it was understated the amount of charity care given by nonprofit hospitals by about 500%. Got the wrong number on that. And also the amount of money or income that at least the nonprofit world, I don't know about the for-profit world, but the nonprofit world, he said that they make about 11%, and that is not accurate. I think any hospital today would be very happy to make 11%. Last year, our system, which has 32 hospitals, made 2.8%. So, which has to then go to be reinvested and fix the roof and buy the new piece of equipment and so on. But nevertheless, apart from a couple of things, that is a very telling story about real people who had real problems in taking care of their care. There are other voices coming out talking about value and how do we pay for results. So this is getting some real traction. The efficiency challenges are how do we eliminate unnecessary procedures, unnecessary administrative costs. In a very complex world, that's hard to do. Re-engineering processes is not easy. We have found that the best way to do that is to get non-healthcare people, often from other business sectors, process engineers, to re-engineer healthcare processes. And one of our regions won an international award on that last year in Southern California because they have all kinds of folks come in and they'll look at how the patient flow works and said, why are you doing it this way? When healthcare workers say, well, we've done it that way. They say, well, what about this way? There are ways it can be done, but it is not easy. It is not easy at all. And here's the biggest barrier, I think. What you call waste, I call my income. If I'm a medical device manufacturer and I am bidding for your devices in your hospital system, and you say you only want to have a couple of devices because if we have to stock 10 different devices, that increases overhead and cost of the patient, even if the doctors like sample 1 through 10. So we've got doctors together and others are having conversation, you try to get down to a couple where you're losing people out. I may define that as waste, but that's the income to that sales representative and to that company. You can imagine that they don't go quietly when you do something like that. The other thing that's very difficult is if you re-engineer processes, you may not need the same kind of people. You may not need as many people. And so restructuring of healthcare delivery systems can create pain internally. We're going through a lot of that in our system right now, and colleagues are losing jobs. That is not pleasant. Are we better? Are we more efficient? Are we more cost effective? Yes. But is it painful? Absolutely. Absolutely. So who's responsible for the efficiency? Is it consumers? Is it us? Is it the providers? Is it the hospitals and the doctors and the nurses? Is it the insurers who are paying for this? Is it the suppliers who are giving us our drugs and our medical devices and our equipment? Is it the government? How are we going to get efficiency? Again, is it all of the above? And one more area. How do we get personal responsibility for our health? Who should be responsible for my health? And immediately I say me. But then when I get sick, who should pay for my care? Is that also me? Just me? All of us? Should I pay for you if you get sick? That's the tension that Paul was talking about. That's the tension that we haven't quite figured out and that we're still debating. Quiz. What percentage of American adults, adult Americans, do you think do these four things? Don't smoke, eat fruits and vegetables, exercise 20 minutes 3 times a week, and are at appropriate BMI, body mass index, which means basically your weight's in pretty good shape. What do you think the percentage of Americans who would say yes to all 3 of those things would be?
10.
Yes? 25?
10.
15?
10.
10?
I was close to this 10.
3% of Americans can say yes to all those things. One of the scary things is that 10% couldn't say yes to any of them. So what do we do with that? What do we do with our bodies? Is that my personal right? Is that a community responsibility? Should we stop big soft drinks in our community? Should we label trans fats in our foods? Should we remove sugary drinks from our school cafeterias? Who's responsible? The challenge is that personal action leads to community consequences. Here are some of them. Just a couple. The annual incremental mean healthcare cost for a smoker ranges from $1,275 to $1,400. If I choose to smoke, is that my choice? And what happens if my health suffers? Who should pay for my care? Obesity, which you're going to have a special program on this, which I think would be wonderful. This is a very recent study. It is controversial, but this group of researchers concluded, and again, these are not people off the internet, these are serious folks, that obesity is estimated to account for 21% of all medical spending generally. One of the reasons is the number of allied health problems that are related to obesity. It's not just cardiovascular disease, it may be cancer, it may be other kinds of things, and the downstream effects of that. Another group of researchers said that if we just reduce the rate of obesity increase, by 1% a year, it would reduce healthcare costs by $85 billion over the next 20 years. And if we maintain where it is, it would be $550 billion saved. Be good to find it. This is not the answer, I don't mean to say that. But is it a factor? It's one of those areas where what's the right answer about this? This is an interesting way of looking at healthcare spending. Look at this one here. The top 5% of healthcare users account for almost 50% of healthcare spend. 5% of the people account for 50% of the spend. This other one is, if you took the top 50%, not just the top 5, but the top 50% of healthcare users, they account for almost all. And the bottom 50% account for only 3%. Now, if you're an insurance company and you look at that, who do you want to insure? One of the reasons why there is a mandate as part of this healthcare insurance package is that if all of these folks get in one risk pool and all these folks get in a different risk pool, you can imagine the cost of the people who are in this risk pool. So if I'm 27 years old and I'm healthy, I don't want to pay insurance because I'm going to live forever. And we know that when we're, maybe not 27, but I mean when we're 20, we know we're going to live forever, right? By 27, we may have had some bumps and bruises. But if I do get sick and I'm uninsured, then who pays the bill? When I end up at the hospital or when I have a serious car accident, who pays the bill? Well, anybody who goes into that hospital pays the bill. It's called cost shifting. So we end up doing it one way or the other. So the idea is to try to get all these people in a comparable risk pool to spread the risk. One more, end of life care. How do we want to end our lives? Now, I'm not talking about people who are in accidents and in ICUs and so on. I'm not talking about that. I'm talking about people who are at the end of their life. I'm dying, grandma's dying, my friend is dying, my father's dying, whatever that is. And we know that. With reasonable medical certainty, we know that. How do we want to spend that time? It is amazing how many folks who are not able to answer that question for themselves end up dying in intensive care units. And is that what we really want? Most of us would say, no, we don't want to spend our final hours unable to speak, drugged, hooked up to machines. We'd like to be able to spend our final hours, if we're able to, conversing with our family and loved ones in reasonable comfort. We want to have comfort care. It is sad, and all you have to do is to talk to some chaplains or doctors who are in these conversations in our hospitals. It is sad how many family members cannot let go. Maybe you know stories about that. If you haven't heard them, just talk to any chaplain or any physician who deals with people who are dying often. And it is sad to see how many times, sometimes people who have even said things to their physician haven't put it down in writing. Don't let me be hooked up to tubes when I'm dying. And how many then family members say, I can't let mama die. Some of you may have seen a PBS special on healthcare called Money and Medicine, played last fall. Fine special on some of these issues. It was a very sad story about a son who could not let his mother die. She was dying. The machines that were available to her kept her alive, kept her body alive for a period of time. Months and months and months. And finally, the physicians at the ethics committee in that hospital said, we can't do this any longer. This is not ethical. But he couldn't let her go. The bills on that were hundreds of thousands of dollars. Medicare paid for it. So what do we want? So when we look at the responsibility challenges, who should care for my health? There are certain socioeconomic factors that impact my health, and taking care of my health takes real effort. This is difficult. What responsibility do I have to the community for my health and for my health decisions? Not an easy question. It's very hard to talk about these things in public. All we had to do is to look at the conversation around the Affordable Care Act. When a private conversation between a physician and a patient was added to possible payment by Medicare, that's what that was, all of a sudden that private conversation turned into a death panel in politics. This is tough stuff to talk about. Right before in the fall, before the Affordable Care Act was passed, we heard about pulling the plug on grandma. That's great political rhetoric. It doesn't shed any light on the difficult issues that we're talking about. So these are hard things to talk about. How should the community control, or should the community try to control health choices? And what responsibility does the community have? So when we put this all together, the question is, who should be accountable for health and health care? Should I bear all the consequences for my health choices? Should the community punish or abandon me because of my health choices? That's my right. Is it my responsibility then to pick up the consequences of my actions? Or should we all bear those? Right now, our answer is, you can't turn, if you're a hospital, you can't turn anybody away from your emergency room. Can't do it. So we've said somebody has to take care of people who are in dire straits. We've said that as a policy choice. It's written in the law. We will not abandon people on the streets. But when they end up in the ER, whoever goes to that hospital ends up paying for it, one way or the other. And what responsibility should the community, all of us, have for health care? These are not easy questions, and I don't mean to make light of any of them. They are questions about my responsibility, my rights, and what we do together around healthcare. We are headed for a whole lot of change. Some of it's going to be very difficult. Some of it may not work. We are in a time of experimentation. It is quite clear that for all the good that we hope the new law does, it's not going to solve all these problems. It builds on an existing system. It tries to make an advance in insuring 32 million new people. But it's not going to change our incentive systems. Fundamentally, something else is going to have to happen. So this conversation around healthcare isn't over in 2014 when the Affordable Care Act comes into play. This conversation is just beginning. And I am grateful to the Mansfield Center and to all of the participants who are willing to engage in this conversation. You have to have facts, and you have to have the conversation. So thanks to the Mansfield Center for sponsoring this conversation. Glad to be able to be with you this evening.
Thank you so very much, Jack, for sharing those perspectives with us. I think you have given us good fodder to deal with in these next 2 days. And with that, I'm going to bring the first session to a conclusion this evening. Thank you so much. Please look at your schedule and join us tomorrow. And tomorrow evening again, Thursday, we will focus on what's going to happen in Montana, as well as the future of healthcare in America. Thank you for being here tonight.